It's my great pleasure to introduce our next speaker, Dr. Dyer. Dr. Dyer is the Chief Medical Information Officer and the Head of Musculoskeletal Interventional Services at East River Medical Imaging and a Clinical Assistant Professor of Radiology at Weill Cornell Medicine. He is a board-certified musculoskeletal and interventional radiologist specializing in diagnostic musculoskeletal MRI and ultrasound-guided procedures. Dr. Deyer has written and co-authored numerous peer-reviewed articles in several professional journals, and as well as several book chapters. His research interests include the application of AI to radiology and radiological evaluation of cartilage. He completed fellowships in interventional radiology at St. Luke's Roseville Medical Center and in musculoskeletal radiology at the Hospital for Special Surgery. He was a radiology resident at the Mount Sinai Medical Center, where he was a chief resident in his final year. Dr. Dyer received his MD from the University of Michigan, where he graduated in the top 5 of his class and was elected to the Medical Honor Society Alpha Omega Alpha. He also completed a Master of Science Engineering in Biomedical Engineering and Bachelor of Science Engineering in Medical Engineering at the University of Michigan.
Oh, thanks so much for having me. When Vish and Shayan asked me to do this, I felt like I might be a little out of my league as a clinical radiologist. But I've heard so many of the previous lectures referencing this idea of we need to look at the clinician and we need to figure out what the clinician is doing. And I think that's really important and really teed me up for my lecture. So thanks to everyone else. I also came to the conclusion during Daniel's lecture that I fit in very well to clinician in the pub. I got the right one. So I have been working for the past couple of years on a 3D VLM project with Vish from NVIDIA and Shayan from Mount Sinai. So I'm going to talk about that, but I'm not going to talk about it in the way that the previous lecturers have talked about their projects. I'm going to use it as a framework to talk about how I think these things should be integrated and how I can imagine these types of models being used in clinical work. There we go. All right, so to begin, we should really understand the problem that we're dealing with in radiology. This is a slide from Siemens from a couple years ago. Highlighting how big of a disparity we have between supply and demand in radiology. So the number of radiology studies is going up tremendously every year. We're training more radiologists, but we're not training an adequate amount of radiologists. So this gap that we have is about a 30% disconnect between supply and demand. And that's resulted in radiologists being burned out. In some circumstances, patients not being able to get the studies that they need. Corollary to this is obviously quality as well. As radiologists are forced to do more work, we start seeing more and more errors in reports. So there's about 4% of reports that contain clinically significant errors. And by that, I don't mean just typos. I mean leaving out a no when there should have been a no in there. So something that when the clinician is reading the report, it doesn't read the intention of the radiologist. I should just point out, as we're getting into this, the radiology community has been in this scenario before, right? So when I started training, a long time ago, things were not on computers. So I had to go get film. We had to put the film up and we all had to read the film. It was very inefficient. Films would get lost. Clinicians would take them. We never knew where they were. Very hard to read because you couldn't adjust the film like you can on a computer. But we transitioned to PACS. So PACS is the computer system that we use in radiology to read exams. And that transformation led to an incredible efficiency gain for radiologists. And I would contend that we're probably on the verge of something similar to that now with AI. All right, I think everybody knows this quote. It's been up a couple of times. I can guarantee that every radiologist knows this quote. Right, 2016, Jeff Hinton said, "Forget it. Stop training radiologists. They're done. We don't need them anymore. 5 years, they're going to be totally replaced." Right, and I can guarantee that part of this is due to the lack of radiologists that we saw on the previous slide. Not as many kids have been going into radiology, I think primarily because they're concerned that they're going to be replaced by AI. But assuming he's right, what could we do to solve that gap that we have between supply and demand, right? It's an easy solution. Everybody's been talking about it. Create an AI to replace radiologists. So when I think about that, I think about the things that I do day to day, right? So I sit down at my workstation, I'm presented with a study, whether that be a CT or an MRI. I first have to know the anatomy. So if I'm looking at a knee MR, I need to know all the pieces of the knee MRI. I need to know where the ACL is. I need to know what it normally looks like. I need to know where the medial collateral ligament is. I need to know where the meniscus is. After I know those things, I need to identify any pathology that's in those anatomic structures. I need to know when there's an ACL tear. Once I find all of those pieces of pathology in the study, I then need to integrate those findings. And the integration is really in two different manners. First, 3D integration. So even though I'm looking at a bunch of 2D images, in my mind, I'm thinking about a 3D space, right? I'm looking at a lesion that's in the liver. I'm looking at lymphadenopathy that's in the retroperitoneum, and I'm putting together those findings in 3D space. And while I'm doing that, I'm also integrating those things contextually. So there's lesions in the liver, there's retroperitoneal lymphadenopathy. Now I'm thinking there's metastatic disease coming from somewhere. Now I still look at the images. Is it coming from the pancreas? That's a typical place where we would get metastatic disease to. Could it be coming from the colon? So I'm really integrating all that information spatially in 3 dimensions and contextually in terms of a broader medical domain. After I do that, I create a report, right? The report is my work. That's what I'm showing the other people. That's how I'm conveying what's in those images. So it should be concise, right? It doesn't need to be overly wordy. I need to make it very clear what the pathology is so the referrers can understand the report. I need to make sure I'm addressing clinical issues. If they're asking for why the patient has abdominal pain, and the first thing I talk about is a benign lesion in the bones, who's going to care, right? I need to address things appropriately. But obviously, if there's an unexpected finding, I need to address that as well. So if someone came in because they have abdominal pain and I find they have cancer, it's very important to convey that information. Communication, obviously very important, right? And that's both to the referring physician and the patient. Radiologist really has 2 customers, right? I have a patient that comes in who I'm responsible for reading their study, but I also have a referring physician that I have to convey the information so that patient gets treated appropriately. All right, so let's think about each of those pieces in terms of an AI model. Anatomy, right? We're good at that. Segmentation has gotten incredibly good. Segmentation can go through a CT scan or MRI and pick out all the anatomic structures. So we've got that checked off. Pathology identification, pretty good, right? We have AI models that are currently used in hospitals and clinics that can detect cerebral hemorrhage, can classify thyroid nodules, can look for fractures. So that's pretty good. We've got that checked off. Spatial. So I would contend that 3D evaluation is absolutely necessary for this. So most of the AI models up till now have been 2D analyses, but that's not the way we work, and that's not the way the body works either. You have to have 3D analysis. And fortunately, that's really on the cutting edge. What has everybody been talking about today is 3D models. We have to put those findings in context. Does a pretty good job with LLMs, right? I can if I give LLMs a few symptoms or a few findings, it can oftentimes do a pretty good job of coming up with a potential diagnosis. It's not perfect, as we saw in some of the previous lectures, but it's getting better, and people are coming up with different mechanisms to make it better. Report generation, super easy with LLMs. I actually use LLMs in my daily practice to help me put together reports, to check for typos in my reports. So that's easy. It's in use today. All right, so I'm going to spend very little time on this because you wouldn't want a MD telling you about these models, but I'll just put it up because this is something that Vish and Shan and I are working on, like the other people. And I'll just put it up just to make a point of these things that I do that are being used in the model. So this is our pre-processing, obviously using the segmentation, picking out the different CT windows to look at things the way I would look at them. Because you can't take the raw CT data because it's so wide and really pick out the pathology. So we found that it's much more useful to look at these things the way I look at them in different windows: soft tissue window, bone window, lung window, and look for specific pathologies in those windows. Big chart going over our QA generation. Again, I'm not going to spend a bunch of time on this. If you're interested, talk to Vish or Cheyenne about it. And then finally, the model we put together. So again, I'm not spending a bunch of time on this. I just want to assume that this or one of the other lecturers that you heard today is going to get very good at some point in the near future about doing things that I do. So with that assumption, let's talk about why I still have a job. And I think there's one very important point of why I still have a job, and that's because radiology is not computer science. It's very important for all of you who are developing these models in medical AI to realize who your customer is. And that's both me as a referring physician, as an administrator of a practice, and patients, to make sure we satisfy all those people. So I want to touch on a few things that I think are different in radiology and medical practice in general than are from computer science generating an LLM like ChatGPT that's helping people to write essays. So first of all, we've got the FDA. So I'll touch a little bit on the FDA and regulation in the medical space. Medicine is very dependent on validation. And by that, I mean, we need to have independent validation of the tools that we use, as well as evidence proving that they actually work. So no doctor is going to start giving you something that hasn't had extensive research on it as to whether it works in medical legal, right? That's an important, very important thing. I wish it wasn't an important thing. I wish I didn't have to deal with it. But medical legal is an important aspect of this as well. Cost challenges. And then finally, just dealing with radiologists and their personality and doctors. Doctors are hard people to convince that they need to use technology or change using technology. So FDA, as some of the other lectures pointed out, most of the FDA cleared AI algorithms are in radiology. So there is an appetite in radiology to use these things. The FDA, I think, has been fairly smart about licensing these things. They want to make sure that you have unbiased model data, right? Really important. You can't just train on white nun and expect that it's going to be extendable to other types of patients. So you need to make sure that you have a good wide breadth of data that's being used. You have to prove that to the FDA. And then you have to have clinically relevant results. So relevancy is the important part. So there's not just a set cutoff that says you have to get to a certain sensitivity or specificity, but it needs to be the appropriate sensitivity and specificity. So that's going to change depending on what you're using it for. If you're using it for screening, the risk that's associated with missing something, et cetera, et cetera. And then finally, they require continuous oversight. So you can't just make a model, drop it off, let people use it, and not monitor how it's been used, or it's being used, or how successful it is, which is important. That's what I want, because that's how medical devices work, right? They need to be constantly proven that they're not creating a problem. So very smart with the FDA here. Validation. So medicine is a little unlike other fields. Doctors are cautious for good reason, right? The last thing we want to do is give you a drug that's not going to work or create harm, which is why when we go to medical school, we all recite the Hippocratic Oath or a modern version of the Hippocratic Oath. So it's important when you are developing an AI model in medicine that you go through an independent peer review process. Right? Those need to be people who are unrelated to your research team looking at what you're doing. You need to prove to doctors that what you're providing them actually works the way that you're saying it is working. Medical legal, right? So this is an issue. It's come up 4 or 5 years ago with auto driving, right? If a car is driving itself and gets into an accident, who's to blame? I don't know. I don't know that anyone's figured that out. And it's a whole lot bigger problem in medicine. So I hate to say it, but medical malpractice is about 2 to 4% of all of the money that's spent in healthcare. And that's just direct costs. That's not me saying I need to do another test because I'm worried I'm going to get sued, right? So we're spending a ton of money on medical malpractice. If an AI is making a decision independent of the doctor, what's going to happen if they miss something? Who is the patient going to sue? And you know they're going to sue somebody. So this is something we need to think about. Economic, right? Medicine is a weird business. In what other business do you have no control over the price that you pay, right? So Medicare, insurance companies tell me that no matter how much or little work I do for an MRI, this is what I'm getting paid. So it's a little perverse. So me as a doctor, the only dials I have to turn to make sure that I can pay my employees, pay rent, is to reduce costs. So a little bit of a different scenario. And that's actually both globally and locally, right? So Medicare faces these same pressures of trying to reduce expenditures that I'm facing in my own practice. So from my perspective, the things that will become successful, at least initially, are those things that have a very proven economic benefit. So as one of the previous lectures mentioned, MRI acceleration is probably the most widespread AI in clinical practice now. And it's done for a very specific reason, because there's a clear ROI. Because I know if I take my MRI scan time from 30 minutes to 20 minutes with an AI algorithm, I know I can save X amount of dollars with the tech, or I can get more patients in an hour. Everybody goes up with this grand idea of we're going to make a better radiologist with AI. We're going to have better diagnosis. Super cool. But the reality is, when you try and implement that, you're going to find very little people who are going to be interested in it, because the cost pressure is just extreme. All right, so finally, I say radiologist here. I'm really talking about all doctors. They're very hesitant to technological change. They're just very fickle. They've been doing the same thing they've been doing for many, many years. They get very comfortable doing it. So to change their behavior is very challenging. And I would say radiologists are probably the most open to technological change of any physicians. But even then, it's really a challenge. So in my role as Chief Medical Information Officer, I'm responsible for vetting AI models and incorporating them into our clinical workflow. It's always a challenge. My view, and I'll get a little bit deeper into this later, is the least disruptive, the less disruptive you can be to the radiologists in their working, the better chance you have of getting those into the system. They're protected, right? There was a Scrubs episode. I don't know if anybody remembers that. Maybe I'm too old to be referencing that. But when the radiologist jumped up and down in one of the episodes saying, "This is my CT, this is my CT." It's so true. Like, the radiologists are very protective of their domain. So you need to be conscientious of that. The other thing, as I mentioned before, is Jeff Hinton's quote way drove down the number of radiologists that we're training. That's a big problem, because it's really an inelastic supply. You can't train a radiologist to be a radiologist in 6 months, right? I went to 4 years of medical school. I did 5 years of residency. I did 2 years of fellowship, and I've been practicing as a clinician for 15 years. You can't just dial it up and dial it down. All right, so with all of that in mind, how do I view these things going forward? So I would say my ideal solution to what we're dealing with in the next couple of years of AI and radiology is, don't replace the radiologist, make the radiologist better. So make the enhanced radiologist, part AI, part human, or to co-opt a Steve Jobs quote, AI should be like the bicycle for the brain, right? It should make the radiologist more efficient. So with that in mind, I think we really want to focus on taking these great algorithms that you guys are making and integrating them into the medical practice. So to do that, we need to think about the systems that we use as radiologists. There's basically 4 main computer systems that we use. Electronic health record, right? That's the repository that keeps track of everything that's going on with the patient. And included in that is a radiology information system, so a RIS system, you might have. PACS, which is our a computer system that we actually view the images on. Dictation, so I dictate into a dictation system to create the report. And then billing, to make sure that what gets dictated and done actually gets paid for. And we need to make use of standard transfer protocols. One of the great things that radiology did was have standard ways of transferring data around. So in particular, we're going to look at a DICOM standard, which is actually the standard for the image, but also has a transfer protocol associated with it. And then another standard called HL7, or what will probably become FHIR in the next couple of years, which is a mechanism for transferring both image data, and HL7 is just textual data to move it around between systems. So if I think about how I currently work, studies done on the MRI or CT, images are done through a DICOM transfer to our PAC system. This is where I'm sitting, right here. I'm sitting at my computer monitor with my microphone. So that's my dictation system. I dictate. The HL7 feed goes from the dictation system to the electronic health record. That's the report that I'm creating. In my practice, I also do key images. So I select some images from the study and send those to the report as well. So we use a multimodal report that's images and text. And then that information gets coded and sent off to Billy. So if we think about incorporating an AI system into it, I want to do that with as little disruption to the current workflow as possible. So I would propose something like this. You have the CT or MRI performed. DICOM gets sent not only to PACS, but gets sent to your AI server, which does the evaluation. That sends back a draft report as well as key images to the PACS system where the radiologist is sitting, sends the report to the dictation system, which they're already using. Radiologist looks at all that stuff, looks at the images, and signs off on the report. So there's not really much change to how the radiologist is working. From their perspective, everything is happening behind the scenes. So if we take that previous flow chart and look at it here, so I would add in the AI server here. So we get a DICOM transfer to the AI server. It does processing, sends off a report via HL7 to the dictation system. Through a DICOM sends key images to the PACS system. And I still sit here, same place, right? I'm sitting at the computer, looking at the same stuff. The only advantage that I have is I now have a draft report. I now have circles around the various pathology and the imaging when I'm looking at it. This is a proven workflow, by the way. If we replace AI server with radiology resident, it's the same thing, right? This is what people are used to doing in an academic setting. So this has very little disruption to the radiologist, but potentially makes them much more efficient. So how much more efficient do we need to be? I mean, to be frank, this is probably a little bit of an over-exaggeration. Some research did show that it was about 10 minutes to read a cross-sectional study, probably a little less, to be honest. But if we can just knock out 3 minutes, we close that gap, right? There we go. The radiologists that we have are now reading 30% more from AI assistant here. And now we can get the radiologists so they're meeting the demand. But of course, it's not only that, we can get improved quality. So 2 heads are better than 1, right? We know this. So some of the other lecturers talk about 2 reads in mammography. So second reads do improve quality. I do it in my clinical life, right? When I'm looking at a study, there's another radiologist who's around the corner from me. I say, hey, what do you think about this? Do you think this is X? Do you think it's Y? What do you think? So we know that improves things. So by having the AI as a second reader, we should improve quality as well. And then you can do easy stuff, right? We know LLMs can go through a report. I use it daily to fix typos, so we can make sure that we're putting out a better product. So the hope is with an AI assistant that we can close that gap. So as imaging continues to increase, we're not going to increase the number of radiologists, but we're going to try and make them more efficient. So we can close that gap and make sure supply and demand are meeting one another. So in summary, I think we have a lot of the tools available, or they're certainly coming online soon, to mimic the types of things that I do. So I would anticipate in the next couple of years, we'll have something that can do a lot of what I do. But I think it's important to make that AI work in the medical framework. If you don't have a product that's going to work in the medical framework, you're going to see a lot of pushback from physicians in terms of integration. And my feeling, we're kind of at this inflection point, deciding how AI is going to be used. Is AI going to replace us? And by us, I don't mean just doctors, right? Coders are being replaced. Other lawyers are being replaced. But I would put forward that I think the better way to go forward with this thing is to improve each one of us, make us better at what we do, than to replace us. So, thank you.
So, what a roundup. After seeing so much progress, here's a clinical perspective as well. I would open the floor for questions.
Excellent talk. I am a biomedical engineer by training, and I very frequently collaborate with radiologists, and I can relate to a lot of what you're saying. It's hard to work with them. So my question is, how do we inspire radiologists or trainees? So I work with them in terms of research projects, but they have very limited bandwidth. So what are some ways that you think that we can inspire radiologists to carve out time or to, create sort of a training program within radiology training?
I can't speak for the radiologists that you work with, but my experience is radiologists are very, at least a subset of them, are very technically savvy. So we go into radiologists, I think a lot of us, because, well, we either hate patients, so we have to do something where we're not seeing patients, or we have some type of technical interest, which I think is a larger majority. So I think if you approach them appropriately, I think you'll find a lot are very interested in it. A, because of the technical aspect, and B, because the fear in the back of all of our minds is that we're going to be replaced by an AI. So understanding AI and moving forward, I think is going to make these radiologists better physicians down the road. So I think we'll see the interest there, to be honest. I think we just need to approach them. You're right, though, they're pulled in a lot of different directions. So I think you need to be very conscientious when you're asking them to do work with you, that it's got to be small, discrete ideas, bundled time. No radiology resident wants to be labeling images for 5 hours. It's torture. So you got to think about how you use them because they have a lot of other things to do.
Thank you for your great talk. Actually, I from Siemens Healthineers, thank you for quoted the image. So I have a question about first, my background is computer science. Actually, I'm an AI scientist in Siemens Healthineers. When we talk to customers, so we find that there are some fields that are pretty subjective, which means that maybe radiologist A is not agree, will not agree with radiologist B. So for example, like the medical image segmentation. So A may believe that, okay, in this way it's better, and B may believe in that way it's better. So there were different guidelines, and people have a different training background, right? So in this kind of context, the question is, how should we evaluate our AI model in this kind of, so basically there's no golden standard reference. Yeah. The second part is, do you have suggestions for like the computer scientists when we develop AI models to address those kind of scenario? What should we keep in mind?
Yeah, I think the last lecture kind of went over this idea of in medicine, there is uncertainty, right? You have to address or embrace it because there's not always a right answer when we're dealing with these things. So it is a challenge. I don't know that I have one great answer of how to deal with that. I'm not sure anybody has one great answer to deal with it. But I will say doctors deal with that in their day-to-day practice. You have to make decisions based on limited resources. You have to accept some level of uncertainty. With respect to the disagreement, it's interesting that you brought that up. A couple of weeks ago, I was giving a lecture in Kuwait about EOS, which is an AI product to evaluate thyroid nodules. And all of the radiologists, they really love to try and pick apart the AI, and they say, I don't agree with this, I don't agree with that. And I said, yeah, but you don't agree with your colleague either. So it's a challenge because medicine is different in that way because there's not always universal agreement. I guess I don't have a magic answer for you except to agree that it is a problem.
Yeah, totally. Thank you so much.
Before you ask, it's quite likely that we're not gonna have the last talk, so we do have some time for Q&A in case people want. Oh, you're here? Yes. Okay, we have. Go ahead.
So I have a question about the integration part and the dilemma that exists. One is that adding extra resource from AI into the standard workflow doesn't make like less efficient for radiologists to go to another report? That's the first question. And the second question is that if you read another report, doesn't that impact your judgment? And how do you deal with like trusting your own judgment or the AI report?
Yeah, so I would frame this in the context of this is something that we as radiologists have been doing for 100 years. But replace AI with resident. So I think everybody is familiar with that workflow and realizes that there can be potential bias. But you try and remain independent. So some radiologists will deal with that by looking at the study before they read the residence report. Some feel comfortable because they know and trust the resident. They'll look at the report or skim it, skim the images, and then feel comfortable signing off. So I think that's there. A lot of it depends on trust. So you need to have trust in the resident or the AI system, whatever it may be, in presenting you with that draft report. Which is why I think it's so important to go through that step of peer evaluation, making sure that you've had independent evaluation of the AI tools to ensure that they're doing what you expect them.
Question. So do you think someday there's going to rely on AI system? Like we forward now.
That's entirely possible. That's entirely possible. I would hope that before that day comes, someone realizes that there's, you know, you need to still add value, right? The point is not to just sit there and press return, right? You're not adding value. So I would hope that that wasn't the case. But yeah, absolutely. It's got a potential to be abused that way. Depends on how good it is, I guess.
Well, with that, I'd like to thank Dr. Deyer. That was a fresh clinical perspective. And I'll go ahead and introduce